Hello, and welcome to the second episode of Health Professions Fireside Chats. Thank you all for attending today. I'm your host, Brian Park. So while our country is still fighting COVID-19, we wanted to host these Fireside Chats for everyone to highlight UVM faculty and staff working within health-related professions and call attention to how these folks are contributing to the pandemic response. So for folks joining us, later in the show, we'll have a question and answer portion. So at any point during the show, please submit any questions you have for our guests, and we will select a few to answer during that segment. And a quick note for folks that because this is an online medium, we expect to see a few delays between when questions are posed and when our guests share their answers. So without further ado, let's bring out our first guest. So she works as an associate professor and hospital epidemiologist with the UVM Medical Center. She is also an award-winning recipient of the 2019 Distinguished Clinician Award in recognition of faculty members who are outstanding clinicians with a reputation as a physician's physician, and with exceptional contributions in education, scholarship, administration, and community service. So please, everyone, welcome Dr. Cindy Noyes. Dr. Cindy Noyes, welcome. And if you can start, please tell us more about your work.
Brian, thank you so much for that introduction, and thank you for inviting me to tell you a little bit more about my role in infectious disease and infection prevention. I'm an infectious disease physician, and what that means is I trained in internal medicine after my medical school education, and then after that time, got additional training in infectious disease and have been working as an infectious disease physician here at UVM for the last 10 years. Generally, as an infectious disease physician, we work with patients both who are hospitalized as well as outpatients to try and diagnose and treat their infections. And this may range from people who have bloodstream infections or wound infections or various viral infections like HIV, amongst many others. We also work with immune compromised hosts, so those folks who've gotten infections after they've had immune suppression related to cancer chemotherapy or transplants. And so, they're every day in the life of an infectious disease doctor is different, which is really what the fun of my job is. In addition to that clinical work, I also actually work in infection prevention as the hospital epidemiologist. And so this is kind of like public health for the hospital setting, where we look at systems of care to try and optimize patient safety. So different things that we'll look at are, working with our surgical and operative colleagues to reduce surgical site infections. We look specifically at different types of hospital-acquired infections. Obviously, when people are sick enough to be admitted to the hospital, they're vulnerable to other things that can develop in the hospital itself. For example, things like C. difficile or an infectious colitis that can occur as a result of antibiotic exposure. So we do lots of different things in infection prevention to really try and, minimize harm and optimize safety for vulnerable patients when they're admitted in the hospital. In addition to those things, when there's a pandemic, infection prevention becomes really important in terms of trying to do things like devise PPE or personal protective equipment strategies to keep not only our patients, but also our frontline healthcare workers safe. So we spend a lot of time working on those strategies as a part of a much larger group to try and help keep everyone safe in the hospital. We do things like work with our, nursing colleagues in hospital operations to make sure that, patient flow is appropriate. and review testing strategies. So lots of variability in the day.
Oh, sorry, my mic was muted there. My bad. So yeah, Dr. Noyes, I was just saying, how has your day-to-day work changed in response to the pandemic? This is very vital work. You've touched on that a little bit? Has that been how has that changed and shifted?
In the beginning of the pandemic, basically all of this planning for the response consumed entire days. And so, you know, again, what I suggested was a very small part of what we'd been doing to try and make sure our hospital response was appropriate and safe for everyone. But lots of things have changed in the hospital in terms of, you know, our visitor policy has really changed dramatically to try and keep everyone safe in the hospital. Everyone is wearing masks. I'm not wearing a mask right now because I'm by myself in my office, but if you walk through the hospital hallways, you'll see everyone, not just the clinicians, but also the patients and the visitors wearing masks. Again, really trying to practice, you know, effective strategies to reduce transmission. You know, we screen everyone at the door for not only symptoms, but also a temperature to be sure that if someone does have symptoms before they come in, we can identify them and get them appropriate testing. Most patients who are hospitalized are actually tested for COVID, even if they have no symptoms. Again, lots of different strategies that weren't present before, you know, March, we're now instituting. And COVID is on everyone's minds, obviously, as we sort of work through our day.
Absolutely, and I'm happy to hear that the hospital has been able to put those protocols into place so quickly. So we thank you for the work that you've done there, Dr. Noyes. So I'm going to transition over to our second guest. Just a quick mention that folks, feel free to still submit any Q&As if you're curious, but we'll introduce our next guest. So our next guest is a second-year resident and alum of the Larner College of Medicine, whose research project brought significant improvements to medical education at Larner. She completed the post-bac pre-med program at UVM as well. Please welcome Dr. Elizabeth Carson. Dr. Carson, welcome. And to start off, would you tell us how the pandemic, how has the pandemic evolved from where we started to where we are now?
Thank you, and thanks for having me. It's really nice to get to talk to you all. So as a resident, I'm in my second year of training in internal medicine, which is adult general medicine. And the internal medicine residency is 3 years, and it is the direction of training for folks who want to do general adult medicine, either in primary care or in the hospital, or also people who might want to pursue a fellowship in something like pulmonology, cardiology, gastroenterology. There's really a number of fields that go through internal medicine. So my job as a resident is I spend a lot of time on the inpatient wards, taking care of folks who have been hospitalized with an internal medicine problem. So it's a lot of respiratory, a lot of GI problems. And so our COVID patients who were, some of them were sick enough to require the ICU, the intensive care unit, but some of them just needed a little bit of extra support and didn't have to go to the ICU. So our COVID patients were, when they were hospitalized during the height of the pandemic, were generally cared for in 2 different areas of the hospital and kept quite separate from the rest of the inpatient population. And, you know, for my assignment at that time, I was not working directly with COVID patients, but I was taking care of patients who were hospitalized with other problems. And what we noticed at that time is we were very prepared for a large surge of COVID patients, which fortunately in Vermont didn't come. We had a lot of hospitalized patients, but we always had the resources in place. Our resources were not overwhelmed by that surge. What we noticed on the general medicine wards and caring for other patients is that many people who previously to the pandemic would have come to the hospital with their problem were staying home. They were afraid to come into the hospital for fear of contracting COVID. COVID. So our census during the hospital, or in the hospital in the general wards at that time, was actually very low. I mean, we had the smallest lists that I've seen since I started residency. And we definitely wondered during that time, are people getting sicker and sicker at home, and we don't know about that. One of the hardest things about working in the hospital during that time was not being able to have visitors come in for patients. To provide care for those patients was harder because the communication was much more challenging. Family members would have loved ones who were hospitalized sometimes for a long time without being able to see them. And if they couldn't talk, they might not have been able to talk to them on the phone either. And so we were calling, it became a large part of our day to call family members and give them updates. And it definitely stretched our communication skills, because I found that it's a lot easier to communicate with patients and families when you're all in the room together and you're in person, and especially when the family members can see their loved ones and how sick they are, versus when you're just giving a report over the phone of how they're doing. So since the height of the pandemic, I would say we have seen many more folks come in, and they, by and large, are generally sicker.
Absolutely. And it's interesting to see that the healthcare industry has not been immune to adapting to virtual platforms. So as you mentioned before, with the family members who you've had to maybe engage in that way with using virtual platforms, how has that transition been?
So we started pretty early on during the pandemic in the outpatient clinics, using Zoom as a platform, a secure platform for doing patient visits. And it is a very challenging. A lot of folks like it. A lot of patients like it. As a lot of providers like it. You can work from home, which is nice, but I also find that, your physical exam is very limited when you're on video. So there are some specialties in medicine that have been using telemedicine for a long time, like neurology and psychiatry actually have had a lot of practice with this. In primary care, not as much. And I think there are certain problems, like mental health problems, that actually you can treat pretty well over Zoom. And there are others, like rashes, that are very challenging to treat via telemedicine. Although I did recently have a patient who had a scabies rash, and I could see what it looked like over telemedicine. And I think it was actually really a good thing for infection prevention that they did not come into the clinic. So there are some huge advantages for telemedicine, and I know that it's here to stay and will definitely become a part of our discipline for forever at this point.
Absolutely. Yes, it'll be interesting to see how that forms and shapes as we progress in time. So I think now at this point, we'd like to transition over to our question and answer portion. Again, for our audience, please submit any questions you have. There is one question that we have right here. So our first question is, how has the pandemic affected your patient's overall health? So I'd like to start with Dr. Noyes, if possible, then we'll move over to Dr. Carson.
So sort of what Dr. Carson was suggesting, I think, I'm a consultant in the hospital, which means I see hospitalized patients with infectious diseases. And I think what we've noticed generally is that out of fear and concern and aim for social distancing, people were avoiding coming to the hospital or emergency department for care during the height of the pandemic. And what we've found is that when they do ultimately present for care, that their disease processes appear much farther advanced than what we would have expected prior. And so, we've certainly seen lots of, folks with, wound infections who, ultimately required amputation because, their disease process had progressed. It's hard to know sometimes whether or not they would have required that sort of extreme sort of intervention if they had presented earlier, but certainly that is on all of our minds. And I think that we've seen that happen in other realms as well, other than sort of wound infections and bloodstream infections. And, I'm sure Dr. Carson can comment a little bit more about, those folks not coming to the emergency department who may have suffered heart attacks and now are sort of dealing with the consequences of that.
Yes, I agree with Dr. Noyes, and there are three types of illnesses in particular that are coming to mind and that I've noticed that are a lot worse now that folks are starting to come back into the hospital. Cardiac illness is one. So I was recently on the cardiology service, and there are, first of all, it's full all the time. I mean, there's just many people who are now have deferred their care and are now coming into the hospital. And they're coming in with heart attacks that they had maybe a few weeks ago, and they were never revascularized, so they were never treated for that. And so now there are areas of their heart that are permanently dead and they have new heart failure. So that's a big problem, and I think it would be very helpful if everyone could spread the word that if you have any concerning cardiac symptoms, to go to the emergency department. And then I think the two other things that I've noticed are, so the umbrella of mental health illnesses and also substance use disorders. I think folks who suffer with these illnesses have had decompensating events over the last couple of months. I think social isolation and quarantine has been very challenging, and we're seeing folks who have underlying mental health and substance use disorders coming in to the hospital, often with other problems, but with also sort of a flare and exacerbation of their underlying symptoms of their disease.
All right, fantastic. So we have some questions from the audience here. I'm going to go in order of which I see it. So first question is, are hospitals constantly preparing for a possible pandemic? I guess they might mean outbreak. Was COVID-19 a complete surprise, or was it at least a little expected? I guess I'll start again with Dr. Noyes, then we'll go to Dr. Carson.
So maintaining levels of preparedness for all diseases of high consequence, which is part of what we do in infection prevention, is really important. And it's important to have a baseline readiness, but obviously each outbreak brings its own pathogen with its own sort of transmission characteristics. And so things like PPE, or personal protection equipment strategies for Ebola, for example, is actually different than what we're using for COVID and different than what we've used for H1N1. And so we do try and maintain a level of preparedness for these types of events, but it's hard to have specific sort of preparedness because each of the pathogens that we've encountered, at least in the last 10 years, since I've been in attending, are all a little bit different one from the other. But for example, we fit tested N95s, which everyone I think knows about now, are masks that we use for additional respiratory protection, and we use those to protect ourselves against, tuberculosis and measles and those types of things. So, we keep an inventory of those, knowing how much we need to use, and also do the fit testing for our healthcare workers who have frontline exposure to patients who may be infected with those. So that would be one baseline readiness sort of activity that we're always interacting and performing. But we didn't know about COVID until, December 30th. And so, our preparedness for that specific pathogen had to take part after that.
So I wasn't not nearly as involved in the hospital readiness as Dr. Noyes was. I mean, she has a lot of experience with that. What I noticed from the perspective of, residents are often called house staff, a house staff member, is that, even though the pandemic really sort of crept up, our hospital seemed amazingly prepared to me. And I think it was that we had the fortunate advantage of a little bit of lead time. So we didn't get overwhelmed the way major cities like New York did. And we saw what was happening there, and we're able quite quickly, it seemed like, our leadership to mobilize a lot of resources. The Patrick Gym was a makeshift hospital that we actually wound up never using. Although now that that has been put together, we know how to do it. I think there are a lot of lessons that have come out of getting prepared for a surge that will be very useful in the future. And I think our hospital leadership did a great job of forming committees and having those committees really accomplish a lot very quickly.
Absolutely. Thank you very much, you two. So we have 2 questions left in the queue. Let's start with one and see if we have time for the other. So I see a question that says, I've noted a lot of outreach recently on behalf of the hospital to say, quote, "We're here for you." Are you all noticing folks coming in any sooner since the outreach began? So for this question, can we go with Dr. Carson first and then Dr. Noyes?
It's a challenging question to answer because we are seeing people present sooner than they did during the height of, I guess I'll say during March and April. I don't know if that's the result of the outreach that's being done or the result of people generally growing more comfortable with moving around in the community. I think we're learning more about how this virus is transmitted and how to effectively protect ourselves. The economy is starting to reopen. And so I think people are learning how to move about safely. I hope that the hospital's outreach efforts are helping, and I would suspect that they are to a certain extent. I think the other things that are helping are us learning about the virus transmission, how to best protect ourselves, public announcements to that effect. I think the governor has really done an exceptional job in getting the word out about that, and and Dr. Levine also as the health commissioner in describing, what people can do to protect themselves. But there is still a lot of fear about COVID, and it's justified. It's a scary virus. But there are still many patients that I see who continue to be reluctant to come into the hospital or the clinic. And fortunately for them, we have methods like televideo medicine where we can at least reach them.
I would say I completely agree with Dr. Carson in terms of, I think our outreach efforts are helpful. And part of the outreach has been to be specific with the things that we're doing to try and help protect not only our patients, but the healthcare workers from transmission. And, sort of this is what you should expect when you come to your, outpatient appointment. These are the things that, you should expect if you come and have your hip surgery done. And so I think that education actually has been really helpful. And we want to provide people that information because, number one, we want them to know all the things we're doing to help protect everyone from, sort of developing COVID, not only in the community, but also in the hospital or outpatient setting. But the look and care sort of in the hospital has changed a little bit in terms of, it could be alarming for people, to come to the hospital and see everyone in masks and, to have their temperature checked before they walk in the door. I think it's really important to let people know these are the strategies that we're using to help keep everyone safe.
I keep forgetting that my microphone's muted, and I'm sorry, everyone. I'm not usually like this. I think for our 2 guests, do we have time for the last question? Would that be all right for you two? Yep. All right. Fantastic. So our last question is, what about your career is as satisfying as you thought it would be when you were pre-med? And then a follow-up, what are 1 or 2 things that are significantly less enjoyable about the career than you expected? So let's just, again, same order. Let's go Dr. Carson, then let's go Dr. Noyes.
So the parts that are as satisfying or maybe even more satisfying than I thought would be just the atmosphere in medicine of constant learning. Everyone that we work with, from folks who are still in training to people who are nearing the end of their careers, is still always learning. They're always looking at, performing new research, they're reading journals. We meet weekly for a conference called Grand Rounds. Our whole department comes and we just learn new things together. So I think the atmosphere of learning is very satisfying. I think the collegiality and getting to work with folks of all specialties and seeing people do what they do best and then working together to help individual patients is extremely satisfying. And then I would say the part that I guess I never expected to enjoy, but I do find to be a bit of a strain, especially at my stage in training as a resident, is the electronic documentation. I mean, there's just like a lot of, I think our electronic health records they could use more efficiency. I think we're at a point in technology and informatics in healthcare where we could do better with our record keeping and be more efficient and make more time for patients. And so any of you out there who are really interested in informatics, have I got a job for you? And I think that you could find plenty of opportunities for improving electronic health records.
So I would echo Dr. Carson's sentiments, both about the sort of every day we're learning something new. And although that may seem challenging and overwhelming in the beginning, it's really sort of what fuels our fire to sort of keep going and learning, you know? And so that piece I think is incredibly important. My day is not one day matches the next. It's very unpredictable. And that's the part that I really enjoy. It makes sometimes scheduling challenging, but at the same time, I think if you can roll with the punches, it's incredibly satisfying, and I won't say exciting, but you know, keeps people's interests. And you know, I can move from a really sick person in the ICU to someone who's, you know, not hospitalized and you know, quite healthy, but we're, you know, minimizing risk for heart disease, and all within a day, which I think is really fun and interesting. My favorite part of my job, though, is the detective work. We are the sleuths. We, you know, call around, we try and get all the details, you know, and really go through a very careful and systematic diagnostic evaluation. And that's the real fun of my job. I really enjoy that. Through that, I get to work with lots of trainees at different, you know, levels of education. Dr. Carson and I were on together a couple weeks ago, and it's really fun to learn from one another. And I really enjoy working with patients. In terms of things that no one really likes to do, I would agree the documentation piece is always the tough part. We do it grudgingly because we know it's important, but it's not the fun part, that's for sure.
Well, I think it was a lovely note to end on for both of you. Thank you so much for your time. So we'd like to thank our guests, Dr. Noyes and Dr. Carson, for taking time out of their very busy schedules to share their thoughts and wisdom with us. So please tune in on Wednesday, July 22nd at 1 p.m. for our very next episode, which features medical laboratory scientists. So until then, thanks for watching and stay safe and healthy, everyone. Goodbye.